Hello, everyone. This is Captain Antoine McCoy with Greensboro Fire Department's Training Division. Welcome to EMT Continuing Education 2020. Due to COVID-19 pandemic, we are in guidelines with the CDC, state and local protocols concerning social distancing and quarantine. If you have any questions on anything, please contact me at 336-430-6047. EMT continuing education will comprise of trauma and documentation. There will be a 25-question quiz at the end. So please pay close attention. Your instructors today will be Firefighter Tamika Brown, Firefighter Jonathan Bryant, and Firefighter Adam McClanahan. Thank you and hope you enjoy.
Okay, as Captain McCoy stated, this will be on trauma overview. Setting the stage, I'm not going to read all of them, but I will be focusing on the kinetics of trauma and mechanisms of injury. So this case study, these are EMTs that responded to a report of a person in a hunting accident. After a 15-minute response to a remote area, they meet state police on scene. It is confirmed that it was a hunting accident. All weapons have been secured, and the man was accidentally shot by another hunter. This is going to be a high-velocity injury, so that's just something we're going to work on talking about. As EMTs size up of the scene, they see an officer holding direct pressure on the patient's thigh. The patient is laying on his back, is combative and confused, pale and sweaty, despite the temperatures outside. So in managing this patient, the priorities, as we've talked about so many times, will be ABCs initially: airway, breathing, and circulation. In this case, because it was a high velocity injury, circulation is probably going to be your first go-to. And when you arrived on scene, the police officer was holding direct pressure, so you can imagine there is quite a bit of hemorrhaging. Information that would be pertinent, you can get that from the police officers on scene, the other EMTs on scene, and just kind of see what he was looking like when they got there, the actions and steps that were taken prior to our arrival. So trauma makes up a very large percentage of calls to which pre-hospital personnel respond to, and that would be EMTs, firefighters, police officers. The data compiled from the Department of Health and Human Services, and this is just for 2018. The statistics for 2019 and obviously 2020 just started haven't been released yet, but the information compiled as the overall leading cause of injury deaths, and this is just for Guilford County. In this order, the first is unintentional poisoning, the second is unintentional falls, the third is motor vehicle injury deaths, fourth is suicides, and fifth are homicides. Deaths due to motor vehicle crashes have been on a steady increase since 2011, along with mortality rates due to non-motor vehicle related injuries. So, kinetics of trauma, everyone is well aware of what MOI stands for, mechanism of injury, and this is how the person is injured. The science of analyzing mechanisms of injury is the kinetics of trauma, and kinetics is the branch of mechanics dealing with the movement of bodies. Understanding kinetics is helpful in understanding injuries. Here is the equation, and I'm sure we're not going to be out here responding to calls thinking about this equation, but this does give you a better understanding as to kinetic energy and how injuries do occur. So mass and velocity, kinetic injury equals mass times velocity, and velocity is squared divided by 2. Velocity is a more significant factor in determining the amount of kinetic energy exerted. So, for example, the mass of a moving object is doubled. If the mass of a moving object is doubled, the kinetic energy is also doubled. As noted in a previous slide, velocity is squared, which means that the kinetic energy of two moving bodies that collide combine to determine the total amount of kinetic energy involved. Okay, so velocity helps estimate the speed of the objects involved in motor vehicle accidents, penetration traumas, and much like that case study we talked about with the gunshot wound. The way of the bullet isn't as important as the velocity at which that bullet was traveling. So, with that being said, the greater the velocity, the greater the destruction to tissue. So more on kinetics of trauma, acceleration and deceleration, and the law of inertia, also known as Newton's law, which states a body at rest will remain at rest, and a body in motion will remain in motion unless acted upon by an outside force. Okay, so I'm going to give you another example. If a car is traveling at 50 miles per hour, this means any and everything within the car is also traveling at 50 miles per hour. So we're talking boxes, we're talking dogs, children, body organs within the body, of course. I hope no one's riding around with organs in their car, but this is talking about organs inside the bodies of the passengers. So according to Newton's law, these bodies will continue at 50 miles per hour in a straight line until acted upon by an outside force. More on kinetics. Energy changes form and direction. So, as I stated, it travels in a straight line unless it meets interference. And interference with travel of kinetic energy can cause it to change direction and form. So, we're going to talk about the three types of impacts. Energy is absorbed in each impact, and these are motor vehicle accidents. So we're just going to focus on that. So vehicle collision, that's the vehicle actually hitting an object, a tree, a pole, another car. Body collision, and that is the body hitting contents in the car, the steering wheel, the windshield. And then organ collision, which talks about, your organs inside your body. And Jonathan Brown will talk about this a little later, but your brain inside your skull and that type of thing. Here's some photos. This just basically illustrates the vehicle collision, and that is the vehicle hitting an object, immovable object. Body collision. So the occupant continues forward and strikes the inside of the automobile. So steering wheel, windshield, like I talked about earlier, the contents within the car, the boxes. Heaven forbid, everybody knows how much I love animals. The poor dog. All of this can cause some significant head, neck, and chest injuries. Organ collision, and like I said, Jonathan Brown, he'll expound upon this later, but organs continue to move forward and strike the inside of the skull, the chest, the abdomen, and a lot of times these won't become obvious injuries until much later. That's why you ride these vehicle accidents, and a lot of times people are like, I'm good, I don't need to go to the hospital, and we know better than that. So, and this is the reason why. So, factors that most significantly determine the amount of kinetic energy involved in a vehicle collision, and this is just going to list 4 different things: the gravity, the mass of the vehicle, the mass of whatever the vehicle strikes, and the combination of whether the other moving object was actually moving or not moving, immovable. mechanism of injury. So, we know that the mechanism of injury provides a suspicion of injury. Not an accurate indicator of injury. Let me say that again. Mechanism of injury, I can't talk today, provides a suspicion of injury, not an accurate indicator of injury. So you must assess the patient for indicators of injury. Even if, like I stated earlier, they say we're good, I don't need to go to the hospital. I think we've all ridden enough motor vehicle accidents to know that just because they aren't presenting with an injury right then doesn't mean that they aren't injured. Vehicle collisions. Okay, vehicle collisions have a high suspicion of injury when there is 1, death of another vehicle occupant, 2, an altered mental status, intrusion over 12 inches for the occupant's sight, ejection, obviously, from the motor vehicle, and just the data compiled. And this picture is just going to illustrate where, and we'll talk about this later, different impacts can be front, rear, and it's just basically, and I think you're probably going to talk about this later, where you run into the most incidents of front, rear, and side damage, urban areas.
Yeah, well, not necessarily where, but we'll talk about the injury sites that you most commonly see, type thing, but not like urban or suburbs. I don't think farmers get injuries like that. They get rolled over by tractors.
Oh. So, mechanisms of injury. He's trying to be a smart,
I'm trying to get you to relax.
And mechanisms of injury, vehicle collisions, frontal impact. The occupant is traveling, as we talked about earlier, at the same speed as the car and other contents within the car. So if the car is traveling 50 miles per hour, that occupant inside the car is also traveling at 50 miles per hour. And this is just another picture of frontal impact. As you see, it hit a tree. Car hit a tree. That is some very significant damage. So you can imagine what the patient's organs feel like, even though we can't see that. Okay, in a frontal collision, the occupant continues to move forward. I talked about this earlier, at the same speed as the vehicle was moving. And I wish this was a video because you could see, even though the car has already made impact with the other car, so the blue car has already made impact with the red car. In the video, the occupant is still continuing to move forward even after that. Mechanisms of injury. And we're still talking about frontal impact. With an up and over pathway, look for injuries to the abdomen, chest, face, head, neck. Okay, so this is the up and over, and this illustration is a really good one of that. You can see upon impact, the patient actually goes up and over the steering wheel, and obviously they are not properly restrained. So, deformed steering wheel, and that's another thing. A lot of these cars, most cars, I would hope all cars at this point, I'm sure, have airbags that will deploy upon impact. Well, you will need to lift that airbag up to see what type of damage is caused on the steering wheel. So you can then determine whether or not it's an up and over or down and under injury. And that's just this is going to be an illustration of the paper bag syndrome, which is a direct result of impact with the steering wheel. So the chest is compressed with the steering wheel, and that does affect your internal organs, this one being your lungs. Also, I wanted to go back to the deformed steering wheel, which I meant to cover. It's important to note that hopefully these people will have good restraints, and that means the headrest is where it needs to be, and their seat belts are where it needs to be, and so it will minimize the steering wheel damage. But again, you will need to lift that airbag to make sure you know what type of injuries you're looking for. So we talked about up and over, and this is on frontal impact. Now we're going to talk about down and under pathway. And these injuries are most commonly to the knees, the femurs, the hips, and the spine.
I saw you skip that big word.
I did. Because it would be this time that I pronounce it absolutely wrong, and I do not want to deal with that right now. You want to say
no,
acetabulum?
Acetabulum. Acetabulum. That's what we're going to go with.
Okay, acetabulum. He's picking at me, y'all. So down and under pathway causes impact to the knees. As I said, the knees, femurs, hips, the acetabulum is that we're going with,
that's what we're going
and
with.
the spine. So this happens on frontal impact. Now, when you hit the steering wheel and your body goes up under the steering wheel, this next slide is a better representation. You can see how the top one. I can't even. Sorry, y'all. Hold on. Okay. So this is a down and under. Injuries to the pelvis, the femur, and the person goes up under the steering wheel. Mechanisms of injury for rear impact. I think this is where I'm ending. Is that it for me?
Yeah, but see, I still want you to interact with me. So.
I'm gonna interact. I'm gonna pick at you like you picked at me.
All right, guys. Hey, first off, thank you, Tamika. That was really cool, especially seeing as this is our first time doing this, and if the city stays on lockdown, we'll probably be doing more things like this. So just bear with us. We're learning how to be radio hosts, and if anybody's out there that's ever done a radio show, my hat's off to you because this is a lot harder than what we think it is. But let's get back to it. So we're going to talk about the rear end impact. Now, with me, I'm not going to tell you every point and bullet, but what I want to do is I want to highlight a couple of things. So the first point, they're talking about that the head and the neck, they're whipped back and forth. What type of injuries does that happen, or what type of injuries does that cause? It's that little funny word that we had back in the day. I don't know if it's French or whatever, but it's the coup contre coup injuries. So I'm a real visual learner, so a really good way to visualize this and to see why this is such a dangerous effect on us is to take your boiled egg, go ahead and put it in some water, and then just shake it. Shake it a whole bunch of times, and every impact that boiled egg hits on the glass of the container, it breaks the shell. That's your brain. Now, when you start getting impacts on your brain, what happens? What happens, Tamika?
Swelling,
bad things.
Swelling.
Say bad things.
Terrible.
There we go. Terrible. That's a whole nother class. You're getting all into other stuff. There's just bad things happen. And we don't want bad things happen in our brain. We get swelling. We get contusions. None of that stuff is good. So that's really important for us to remember that. Now, what's the point in us going over all this right here? Is to get us to understand how important it is for us to slow down. I'm just like you guys. When I see a good 1050, or it's just something, an injury that you don't normally see, somebody falling off of a ladder, off the roof or something like that. You don't see that often, right?
Right.
So we got to slow down because we get so excited, we get so tunnel vision in there that we start to overlook things. And one of the simplest things that we can do is we can just look at our patient. We can look and tell if their brain has been jostled around their head because they're going to start to show signs and symptoms of some serious injuries if it was bad enough. So let's go on to the next one. A properly adjusted headrest and seatbelt can reduce injury. Now,
I think I said that.
You did, but I want to touch on the seatbelt part because a lot of us, we sit there and we see properly, and how many times have we gone down the road and we see people put seatbelts on and then they put the shoulder strap behind their back, or grandmama got a little baby sitting in her front lap because we think we can hold on to those little projectiles and making. That's not it. A properly adjusted seatbelt is one that goes across your hip bones and it goes across your chest and not your neck. That's really important because if an impact happens, if that thing is going across your belly, what's going to happen? Say bad things.
Bad things.
Bad things.
I was going to say bruising and go into detail, but I'm just going to say bad things.
Well, because we're going to the bruising in a little bit. Yes, bad things. And if it's going across your neck, what can happen?
Bad things.
Bad things. We don't want a collapsed trachea. We don't want broken cervical spine vertebra. We don't want any of that. So when we come up to the scene and we're looking at our patient, slow down. Look and see how you find the patient. When you see them, did they have their seatbelt on the correct way, or did they just have a lap belt? Because that's going to tell us if there's more injuries that we need to be aware of, or anything like that. Now, at the end of the day, is that going to change how we handle the patient? No, we're still going to do ABCs. We're going to make sure that we do C-spine stabilization. We're going to do all that, but that will help us to kind of fast track some of the supplies that we may need, or it may give us a better idea of what we need to focus on when we're dealing with the patient. You good with that?
Mm-hmm.
All right. That's a nice little picture of a good old 1050 rear ending. Just from personal experience and from North Carolina state law, guys, we put ourselves in a big red zone, bullseye zone when we're out there in the streets taking care of these car wrecks. If they're relatively simple like this, it's in our best interest to work on the opposite side of the traffic flow. So if the driver's side is exposed to it, let's get on the passenger side, see if we can work on there. But if it's in the middle of the road or whatnot, if at all possible, let's try to move this out the way so we can get all our workers out of the highway or off of the road, because these people, they're not paying attention to us. They just want to rubbernet, take a picture of you, and God forbid they might hit you. Okay, so if at all possible, if there's no serious injuries and the cars are movable and your captain says it's okay, please, guys, let's just move these to a safer spot so we can operate in a safer zone. All right. So the effects of driving not wearing a seatbelt is pretty self-explanatory. If you don't have a seatbelt, just like Tamika said, a body in motion tends to stay in motion until it's acted upon by a opposite force. Well, the only opposite force you're going to have is going to be the windshield or the steering wheel, something like that. So that just explains itself. All right. The collisions. Now, when we're talking about lateral impact, it's really important that a part of our scene size up, it should be a quick estimation on how much encroachment, intrusion, what's another word for going into something? Oh no, I don't want to use the P word. That's just
penetrating.
Yeah, there we go.
He was trying to avoid that.
I was. Or how much crumple that you have going into the car itself. Because if we start to take our time and do a quick estimation on this, it can help us to figure out our patient priority, because either they're going to be a high priority, which we're going to reassess them every 5 minutes. They're going to be rapid transport, or they're going to be a regular priority, and we can kind of slow down a little bit. But if you remember a couple slides ago, Tamika said that anything greater than 12 inches on the driver's side, that's a reason for high suspicion of injury. But the CDC also tells us that anything greater than 18 inches anywhere else in the car, that's also a reason for us to be concerned. So, guys, when we're walking up and we're doing our quick scene assessment and whatnot, make sure that you pay attention to that as well. I know that we get there and we want to look and see spider glass, fluids everywhere. We want to see hands out of the window, all that kind of stuff like that. But some of the simple things, like just noticing how big the dent is in the car, that will help us to make our job just a little bit easier. All right, look at that MOI. What was that YouTube video? Do you remember the one they show in training where it's the little character cartoon guys and he's like, oh my God, look at that mechanism. Yeah. That's right there. Look at that mechanism of injury. All right, and just another one. When we're looking at these types of impacts, you can tell that you're primarily going to see injuries to the peripherals of the body. So we're talking possible long bone injuries, like your femur or your humerus. And we know that if we get a femur fracture from this, what are we going to use for it? What's our new splint?
Schlissman.
The Schlissman, yes, the one that everybody hates to use. We're going to be using that. So again, guys, if you had any issues with that particular device during the assessments and stuff, please reach out to the training staff and see if you can get your hands on one, because that is a depreciable skill. It's just one that we don't do that often, but on events like this, you definitely can see it. So it's always good to get your hands on it and just keep up to date on that.
And the protocol for that has changed. Before, it was you can't use it on an open femur fracture. And now, just so I'm sure everybody's fully aware of this after going through trauma in January, you can use those on an open femur fracture.
I actually forgot that.
Yeah, that's one big thing that has changed with the new
Very splint. Cool. All right. So let's talk about the rollovers, the rotational and the rollover crashes. So first off, the rotational one, it's just pretty much the car gets slapped hard enough to where it slides in a circle and it's in a different position. You're not going to really have anything different when it comes to injury patterns than you would a side impact. I guess the main thing is that you're going to have more G-forces put into it, and you're going to have the head being whipped around just a little bit more because it's being spun in a circle. But let's move on to the pretty picture. There we go, rotational. But let's move over to the Hollywood one, the old over and under, the rollover ones. These right here, these are super, super dangerous. They're all dangerous, but they're super, super dangerous for our patient because the patient gets thrown around in just about every direction that you can imagine. And unfortunately, body parts and sometimes the whole person gets thrown out of the car with these. Now, with that being said, if you get somebody that's partially ejected from this vehicle, we run the risk of having them undergoing compartment syndrome or amputations, all different types of really just bad things that can make our job just a little bit more challenging than what we're used to. So we got to make sure that we pay attention to this. Now, when we come up on scene, first thing that we're going to do is we got to make sure the scene is safe. So, Tamika, what's some of the things that we would do for scene safe for this one right here?
You definitely need to make sure that the car is stabilized.
Got to stabilize it because if we get in there crawling around, we might mess around and have that car roll in on us. So, yeah, good. So we're going to stabilize it. Anything else that we might want to do?
You obviously are going to go ahead and get 5 in route because it's an overturned vehicle.
Right there. There you go. Rescue 5. We love you. 5. We love you right there. We're going to get you guys en route. So, yeah, all those things are really important, and we just want to make sure that everything is safe for us to get in there. Now, once we get in there, the actual patient assessment is going to be a little bit trickier just because you might have to figure out how to do this in a very uncomfortable or compromising position. Maybe the patient has been flown over and they're upside down and, they kind of lawn chaired themselves in the roof. You're going to have to figure out how to access places to get pulses and things like that. So if you're not training on things like how to do assessments when you're uncomfortable, that's something that I would really recommend because every call isn't the same. We're not going to always find somebody sitting in a chair, smiling, breathing at us and stuff. Sometimes we're going to have to really wedge ourselves in there and just figure out if the patient is alive. So we know whether or not this is a hey, we got to get going, or this is pretty much a body recovery type thing. Anything you want to add to that one, Tamika?
No, going back to that picture, just making sure that the vehicle is stabilized and creating a safe environment for you to work in is going to be key. Because, you don't want to get into the car. And yes, patient care is we're ready to jump in there and get the work done, but you want to make sure that you're not going to be part of the problem.
Absolutely. All right. Now, let's talk about the mechanisms of injury from a different perspective. Excuse me. I don't know if that came through. But this one right here, it gives us a lot of things to consider when we're talking about injuries for accidents dealing with pedestrians. Things that can make a injury worse or less are things like the vehicle speed, what part of the body that was hit, how the pedestrian was thrown, yada, yada, yada. The main thing that I want you guys to pay attention to is the very bottom one. The one where we're talking about the injury patterns are different in children versus adults. Now, this one is biggie for me because you guys know that I love calling kids tater tots. I don't know why. I just like tater tots, but those are my little buddies. And it's really important that we understand that one size shoe. How does that thing go? One size doesn't fit all. Is that how that's saying?
I think that's okay.
We're going to go with that. One size doesn't fit all when it comes to patient care for an adult versus a pediatric. It's not going to go when we're talking about the assessment for an adult versus a pediatric. And in this case, it's not going to go for the injuries that you're going to see for an adult versus pediatric. So what I did was I went and I looked up on some studies. I went to an insurance website of all places because I thought this was really neat. They actually laid it out without all the rigmarole. But what their study shows is that typically adults will experience the musculoskeletal injuries mainly. Okay, and it's because of their size. When you think of an adult standing in front of a car, you're pretty much thinking that their waist is pretty much going to be at the top of the hood, right? Mm-hmm. Roughly, you're a little shorter, so so you get that. But when you look at a tater tot, what's pretty much going to be at their eye level is going to be the hood. So we're going to have two different types of injury patterns and two different types of impacts when we're looking at an adult versus a kid. So according to that study, it said that the head and neck injuries were the primary injuries for children when it was a pedestrian versus a vehicle type thing. And third most common injury for them were the chest and abdomen. So when we're talking about a kid getting hit by a car, we're talking about almost, it could be almost instant death because we're talking about the cervical spine is being impinged on. Definitely got to make sure we're doing proper C-spine precautions. We're even talking about possible pneumothoraxes because we have a chest injury. We could even have eviscerations if they have those old school Cadillacs and Lincolns with those iron grills on them. Those things can cut you wide open. So all these things are stuff that we need to pay attention to and consider when we're dealing with any type of injuries for pedestrian and versus vehicle, and depending on the age. All these types of things need to be factored in. Anything you want to add on that?
Nope.
Okay. I love your hair, by the way. Thanks. I just want you guys to know that I like her hair. This is very cool. Did you really think you was going to get out of here with that? All right. So, moving on. We're still talking about vehicle collisions, but we're going to just readdress the restraints portion of it. And no, I'm not going to go back over all that, but I just want you guys to just consider some of the types of injuries that a seatbelt can actually cause. And I would like to say that these are primarily improperly fitted seatbelts. But on the research I was able to find, we see injuries like fractures, dislocations. I can definitely see a shoulder being dislocated from a seatbelt if a good enough collision happens. And of course, internal organ damage. Now, Tamika, pop quiz. How can we tell if we have internal bleeding in the abdomen? What's an assessment that we can do real quick? We're just going to
palpate.
We're going to palpate what?
The abdomen.
Well, I mean, you said palpate. Okay, so
we're going to palpate the abdomen.
So how should a normal stomach feel like?
Squishy.
Squishy. Now, for you that have abs, that doesn't necessarily apply to you, but for me, yes, it's going to feel squishy. Yeah. Okay, so if we go and palpate, and what does palpate mean?
It just means you're feeling around, you're checking off for quadrants.
We're just touching. We're just touching. So when we go and palpate the stomach, we want to feel a nice squishiness about it. If we feel rigidity, or if they start to show signs of pain, and if a person is unconscious, what's a sign of pain that they're going to show? What would their body do?
Flinch. If they are going to respond to a painful stimuli, they don't have to necessarily have their eyes open, but they will flinch or move away from.
There you go. Their body is going to react in some way to try to get itself away from the painful stimuli. So if you see any of these types of things, like here, when you're doing your great patient assessment, then we know it was a high likelihood that we have some type of internal damage. So let's say we have bleeding internally. Let's say they got a good perforation inside that gut and there's lots of blood pulling into the abdominal cavity. It's not on the highway that it's supposed to be. We're on some back road, okay? Mm-hmm. What type of, what do we need to be concerned with? What's the main thing that we need to make sure that we get the patient prepped for?
We need to treat them for shock.
Absolutely. We got to get them ready for shock. And we know that our shock protocols have changed over time. And primarily, we got to make sure that we keep that patient warm, get them high flow O2, and we got to get them packaged up, ready to go. That's what we really got to focus on that. And we're still going to hold C-spine. C-spine still takes precedence over pretty much everything, because if we allow their neck to be fully broken, they may not have to worry about shock or anything else for the rest of their life. So good. Anything you want to add on that one?
No. The next picture, though, let's see here. The seatbelt injuries. I know hopefully everybody has seen this, and they actually used to do an air commercial about this seatbelt saved my life. And if you looked at the injury patterns for all the people, they had the same seatbelt impressions. And these are all people that were either cut out of cars, pulled out of a rolled over vehicle, and it was just pretty much a commercial on proper placement of the seatbelt. And if you looked at the injury pattern for every single picture. I think there was 7 or 8. They all looked the same, and everybody lived to tell about it.
Yeah, yeah. That just goes back. I'd rather have a broken chest than be dead. When they talk about CPR, you have to. What's the lesser of two evils?
Yeah.
A couple broken ribs versus dead. So great. This next picture right here, I really like this one because you don't see too many of these, at least not in the textbooks, but it really shows us the effect of somebody just putting that shoulder strap behind their back. Mm-hmm. Lots and lots of people hate the feel of that shoulder strap across their chest. And a lot of times they say because it's on their neck. Well, that just means that it's not a properly sized one for you. Maybe you need to, move over or something. I don't know. They have adapters for it. But this is what happens when that thing goes across your belly. When you get that impact, just like you said earlier, a body at motion tends to stay at motion. So that head and the upper torso and everything is going to keep going forward. But that strap is going to prevent everything else from going. So you see the impact area of that. And I mean, in that area there, we're looking at, what is that? That's around his belly button. So we're looking at some torn intestines, lots of just important things you need to just not going to be happy with you. So this is a great picture for that. All right. Now, let's talk about injuries when it comes to the babies, the little ones, the ones that, we love to death. They stink, but we absolutely can't see life without them. Let's talk about infants and babies. Now, they're typically going to be pretty well protected because if they're in a good car seat, that car seat is in the back seat, so it's away from a lot of danger. It's usually strapped in very, very well, and they're just basically riding around in a bubble, for lack of a better term, of PVC and plastic that really protects them. But every once in a while, we get people who they don't know how to install a car seat very well, or it's just an impact that's so bad that it shifts the car seat. Lots of things can happen, and every once in a while you will have issues like you see down here with babies being hurt. So the main thing that I want you guys to take away from this is that it can happen, but if it does happen, what do we need to do? I think one of the most important things that we need to make sure that everybody here understands is that when at all possible, as long as the baby's not in imminent life threat, that they need to be left in that car seat. If the car seat's not, if the car seat's not damaged, we need to leave them in there because that's a type of spinal immobilization. And, sometimes we get ambulances that are the new ones. Sometimes we get the old ones. The new ones are supposed to have the car seats in them around the captain's chair and stuff like that. But sometimes we don't get the new ones. And you might get an old one that maybe they took it out and they forgot to put it back in or whatnot. So if we leave them in the chair, that child can be transported because the EMS is not going to let the mom or whatever hold the baby in route to the hospital. They do have those new devices. I can't remember those things. What is that thing called? It's that little vinyl thing that they roll out, and it's like what is the name of that thing? I can't remember. You remember? He doesn't exist. Oh, yeah. I can't remember. I will find out the name of it because we actually showed it a couple of EMT cycles ago. It's been a little while, but they do have those on the truck, but they may not necessarily fit the baby. So long story short, if at all possible, leave the baby in the carrier, in the car seat, and transport the baby like that. We want to make sure that we do that. The pediatric seat, what is the name of that thing? It's just the pediatric restraint. Freno is the brand. We're sitting there trying to look it up because I hate leaving you guys on a cliffhanger because I know that you're very interested in it. So, but we will find that out. All right. Let's see. Oh, did we find it? It's the Freno pediatric restraint, and yeah, just pediatric restraint. That's all they say. But I'm sure we'll see some more on that later. Okay, so let's talk about burgundy. That's the color. That's not the.
While they're trying to figure that out, as we talked about earlier, don't forget your pets too.
Oh yes, talk to us about pets. Yes.
I have 2 fur babies, and when I slam on brakes, I get very concerned, especially I got a 90-pound chocolate lab. So she now has a quote-unquote seatbelt.
So how does it, and that's, what, this is a good point. This is a good point, right? So to educate us on how to handle that situation when it comes to fur babies and seatbelts, stuff like that?
Well, it's not. It's to protect them, but it's also to protect you. Because remember earlier we talked about how you're going 50 miles an hour. That means everything in that car, including yourself and other objects, are going 50 miles per hour, right? So it keeps the dog stable in the back seat, keeps it from coming up front with you, going through the windshield, and that's one less impact you have to worry about on yourself. So, I mean, I really just thought about not killing my dogs, but that is something to think about.
That's actually good. Now, from are y'all called fur moms or parent? What are y'all called?
I don't know, but no one can tell me I'm not a parent.
No. I mean,
I have like fur babies in there.
No, I get it. I just want to use the right term. So we're going to say fur parents.
Yeah.
From the perspective of fur parents, when we're dealing with car wrecks, what would you like the first responders to know about the situation when it comes to that?
Well, I think, and I know I'm not the only person that loves animals, but I think, especially if they're in restraints, a first responder will know how to remove them, just like they would know how to remove a human. 90-pound chocolate lab is a big object to move. Right. It is a big body to move, and so hopefully she would still be intact and breathing when the first responders get there. But just cut her out like you would cut
There you go.
Out.
All right, so you want us to make sure we cut them out. Okay, good. That's actually pretty cool. I never thought about that.
Yeah, she's got a seatbelt.
All right. Okay, so let's move on. Let's talk about the motorcycles because, a lot of us out here like to ride motorcycles, and unfortunately, they get into quite a bit of car wrecks on their own. So what's the important thing that I want you guys to really have a takeaway from this right here? Of course, the bullet points that's up here, that's a no-brainer. But I want you to think about, when should we remove that helmet? That's definitely a depreciable skill, and it's something that we need to practice because it is not a one-man, one-woman operation right there. It's something that all the squads need to be working on. So if we look at our textbooks, the only time that we should really be removing the motorcycle helmets or football helmets for that matter is when it gets in the way of air management, if it's not properly fitted and it's allowing for excessive head movement, if it actually interferes with immobilization. So some of these new helmets, they're really big, really beefy, and when you put somebody on a spine board, if you don't have the right padding in between the void spaces and stuff, it can actually put the neck at a really funky angle. So that thing's just not beneficial for that person anymore. And last but not least, cardiac arrest. Okay, you can't drop a king, or it's not easy to drop a king with most of these old school helmets. They do have some of the newer helmets that I was able to find when I was looking at the research, where you pull little red tabs on the side of the cheeks of the mask, and it actually allows the whole front mouthpiece to come out, so you have clearer access to the patient's airway. But that's on a case-by-case basis. When you guys are trying to remove these helmets, make sure that you have somebody stabilizing that head, okay? Because a helmet is a round object. It's a sphere. It's going to allow that head to keep rolling around, and we don't want that, so we got to make sure that we stop that. And then the next person is going to slide their hands on both sides of the patient's cheeks and encircle the patient's back of their neck and head best they can, and then you guys are going to work as a team to slide that helmet off without too much jarring of the neck. So just make sure that you guys practice that sometimes, and that's just a really important skill that we just need to make sure we don't forget about. Anything you want to add on? All right. Just remember, anytime you're dealing with a motorcycle injury, they don't have the four walls of protection around them like a car, so you're definitely going to have some road rash. And road rash can be minor, or it can be all the way to the point where you're seeing bone and white meat. So just be very careful with that and try not to be too rough with the patient if at all possible. And here's a good old picture, a nice little smiley face picture right there. All right. Last but not least on these is going to be ATVs. Now, I love four-wheelers. I grew up with a Polaris Bear. It was one of those little small ones, little racing ones. I had a lot of fun with it, but of course, we're country. We were old school country, not new school country, not disrespecting anybody. I was old school country, so we didn't wear helmets. So we were really, challenging things. I had a cousin, and she flipped over the handlebars of the four-wheeler. And on the way going over it, she actually caught her abdomen and she eviscerated herself. She flipped over and she had about 1.5 to 2 feet of her intestine hanging out as she went over the handlebar, and they found her in a ditch. So I know that's not something that we commonly think about when we're thinking of wrecks dealing with ATVs or even motorcycles, but you got to remember that's metal that's up there on those handlebars, and you hit it just right, you can rip something open. So just be prepared for any type of injury when you're dealing with ATVs or anything like that. Anything you want to add on that one?
No.
I don't think you're supposed to go slow on four wheelers. It's just no
it's
fun.
not. Yeah, that's not how you.
No, you got to ride them wide open, but safely wide open. All right. Let's talk about falls. Falls and being on the bike team, you definitely learn about falls because you're going to fall a lot. It's a lot of fun, but you're going to fall a lot. Depending on, there's so many factors when we're looking at falling that affect the type of injuries that you get. It's not just okay, I fall and now I'm going to have this injury. No, there's lots of different things. If you fall on soft ground versus the concrete, you're going to have different injuries. If you fall from a high altitude versus low altitude, you're going to have different. And even something else that we don't even think about, it's not up here, but your age. Your age. Older people, when they fall, unfortunately, their bones aren't as strong as they used to be. When they fall, injuries happen, and that's not a fun topic to be on, but it is something that we need to be aware of. So you see the statistics or the data right here where we're talking about a fall greater than 20 feet in an adult and then greater than 10 feet or 2 to 3 times the height of a child. We got to add the whole senior citizen portion to it. I don't know if there's a hard, fast rule on the feet from which they fall that we need to be on high alert from, but just know anybody that's up in age, if they fall, we need to make sure that we're focused because they can definitely be hiding some injuries. Something else I didn't think about that just came to me, medication. Some medications can really mess with you. What is it? Prednisone or something like that makes you gain weight.
Mm-hmm.
Things like that. All different types of medications can have unwanted effects on your body, and I'm sure there's got to be something out there that can make your bones not necessarily as strong as they were. So just be aware of that. Now, when we're talking about falls, Tamika, what type of patient assessment should we be looking at for falls? What are you thinking about? Let's say I'll give you the case that we had a couple of months ago. A guy was hanging up Christmas lights, unfortunately, on his roof, and he fell. He fell and he hit his head on the flower bed brick pavers, thing. So you roll up on scene there. What type of things are going through your mind?
I mean, to me, that would warrant a rapid trauma assessment.
Okay.
And you just do your quick head to toe.
Okay.
And look for any. Hopefully, he's breathing. If not, you need to address that. Go from head to toe and look for any major bleeding or any bones sticking out. And then go back and do your secondary.
Absolutely. And I'm glad you brought that up because, during our assessments back in February, some of us had a little issue with figuring out what was important and what wasn't. And just like you said at the beginning, when you're doing your primary assessment, ABCs, airway, breathing, circulation. If that person can't breathe, if they don't have a way to get the air into their lungs, or if they're bleeding out, nothing else matters. So absolutely. Okay. So let's talk about the different orientations when we fall, okay? So if we fall feet first, you have a better chance at dissipating and absorbing the impact than you do if you were to fall head first, because that's just how we're designed. But if we were to fall feet first, you can see injuries like the ones you have listed here.
I really wish we could show them that.
I know, and I want you guys to, I'm glad you brought that up. I want you guys to take a few moments whenever you get a chance, and I want you to go on YouTube and type in guy jumps off a roof onto stability ball. When you see this, you're going to know that the evolution is flawed at some point in time, because this guy should have never been allowed to reproduce or anything, because he thinks that he can jump from a roof onto a stability ball and survive it. So this guy jumps, and of course he misses it, and he lands butt first, not even feet first, butt first onto the ground, and the scream that this guy lets out is absolutely amazing. If you get a chance, look for the follow-up interview. He was interviewed by Tosh.0, and they talk about he broke every bone in his butt. So that's going to be your sacrum, your coccyx. He broke all that. He broke a couple of the lower vertebrae, lumbar vertebrae. and he broke a couple of ribs too because of that impact that went all the way through his body. So definitely take a look at that if you want to see a good example of a feet first fall. All right. When you fall on it, whether it's your feet or your body anywhere, you got to remember that our body is basically a kinetic chain. Any type of impact or force that we experience, it's going to be transmitted throughout our body. That's one of the reasons why our spine is curved the way it is. It's a shock absorber. That's what we're designed to do. We're designed to dissipate the shock that we experience throughout our travels and everything like that. But when you fall incorrectly or when you hit just way too hard, that force can't be dissipated. So that's when you start to see the weak links in the chain start to break. So let's take somebody who has a bulging disc. All right, it hasn't herniated yet. It's just a slight bulge. But if they were to take a good fall, or they just land incorrectly on their feet, as that shock wave goes up through their body, that bulging disc may become a herniated disc or a ruptured disc because it just couldn't handle the force effectively. So that's just a really good example of that. Okay, we've talked about some of this already, so we don't need to belabor that one. Just know that if you land head first, that's just pretty bad. You're pretty much screwed on that one. Of course, you're going to see upper extremity injuries, head and neck, chest and spine. This is going to be a high priority patient. C-spine's a must, and rapid transport. Okay, now, one that I really had fun researching because I wanted to bring something to the table more than just this picture. I'm kind of a science geek if you haven't learned that. You didn't have to roll your eyes, okay? So I really had a good time learning about this, and hopefully I can kind of impart that to you. So let's talk about penetrating injuries. Now, there's going to be a couple different types. You got the low, medium, and high velocity injuries. I want to focus primarily on the high velocity because the science behind it is absolutely amazing to me. I really like that. So, you see on the picture, you see two wound channels. One of them is going to be from a low velocity, like maybe is that another bullet on that one? It could be from a small caliber bullet, like a 22, or even a knife, something like that.
Or like the case study, a high velocity gunshot wound.
Well, that's on the second one. That's the big wide channel. But nonetheless, I wanted to talk about that and why it does what it does. So when we're looking at this picture here, low velocity wounds or low velocity penetrations, they don't carry a whole lot of energy with them. And energy is what really does the damage for us. So real quick, if we were to look at this, we're going to calculate it as force. Okay, how much force is going to be put into the flesh in order to tear it out? So in order to calculate force, we're going to have mass times acceleration. And Tamika talked a little bit about that before. And force is always going to be represented in newtons. All right, so that's just our little foundation, little sciencey stuff. 1 Newton equals roughly 0.2248 pounds. So let's do firefighter math. Let's just say that a 1 Newton equals roughly a quarter of a pound. Just make it simple. All right. I was able to find out that it takes roughly about 4,000 newtons of force to break the femur. Now, the femur is the strongest bone in our body. So we're saying roughly it takes about 1,000 pounds of force to break that femur. On the flip side of that, it only takes roughly 1.22 newtons of force to puncture the skin. So we're talking less than a pound to puncture the skin. So when you get a high velocity impact with like a bullet, you have a whole lot of energy that has to be handled. It has to be dissipated. It has to be transmitted some way. So when it hits the skin, if you look at the bottom, you're going to see that big wide wound, that big wide channel right there. That's a representation of all that energy that's being dissipated throughout the body. And that's what's doing the primary damage. A lot of people think that it's the bullet that does the most damage, but while the bullet does do some damage, it doesn't do the most. The most happens when that channel stretches. And if you get a chance to look at a slow-mo picture or ballistic gel going in and out, it's absolutely incredible. It's that stretching, that violent stretching of that wound channel, and then the equally violent collapsing of that wound channel. That's what does primarily most of the damage in the areas, because you're stretching stuff that shouldn't be stretched, and then you're crashing it back together when it shouldn't happen. Now, there are going to be some exceptions to the rules every once in a while, like a 22 bullet. They say that's one of the most dangerous bullets out there because it can ricochet all over. I'm sure there's some guys that are into reloading and stuff way more than I am. So, my hat's off to you. But from what I've been able to find and research, that's the down and dirty of it. Now, we've already talked about it. The low velocity is just something that goes slow. So knives, shivs, what's another prison term? Shanks. You got any more?
Hopefully, we run into shanking.
Well, I mean, they got the jail downtown.
Very true.
You might have a shank wound. Somebody took their toothbrush and did it. But you have things like that. Any of these things, that as long as it's going slow, it's going to be a low velocity type injury. Just keep in mind that the length of the object can also provide a clue to what could possibly be an injury. So let's say that we take a paper clip. Somebody pops you with a paper clip real quick in your stomach. You really didn't reach past the fat meat that's in there, so you should be pretty good. Versus somebody taking a sharpened toothbrush, the end of a toothbrush, and they stab that in you. You probably done hit the intestines or something like that because it's long enough to go past that layer. So just always be thinking about those types of things when you go on scene and when you're doing your patient assessment. What am I not seeing? That's one thing I really like to ask myself when I'm looking at some unique injuries when we're responding to calls. What am I not seeing? What's something that could jump up and bite me if I don't address it now?
Well, I think that's something we ran into with the trauma assessments was a lot of the injuries weren't obvious.
Yeah.
And so, like this, you're going to see hopefully an entry wound and an exit wound, but you really have no idea what happened inside until you do your trauma assessment.
Yeah.
And see what tissue was damaged, and see if it went anywhere, if it went straight through, if it went up in an angle. So we ran into that, and that's something we need to brush up on.
Absolutely. Cool. All right. Here you have your medium to high velocity injuries, and that could be something as simple as a shotgun or like an AR round, something like that. But am I wrong? Oh, but that's what you're looking at right there. And remember, the high velocity ones are the ones who have that big cavitation, that temporary wound channel that does a lot of damage. So just keep that in mind. All right. Let's see here. Now, when we're looking at the penetrating injuries, it says that the damage is determined by the trajectory and the dissipation of energy. I've already talked about the dissipation of energy. I'm tired. Mm-hmm. But let's talk about the trajectory. What makes the trajectory so bad? One of the first questions that anybody's going to ask when we're talking about a gunshot wound, especially on law enforcement side of it, is, was it a through and through? Did that thing go all the way through? Because if it goes through, if it's going in a straight line, we pretty much can estimate roughly what was hit. If I get shot in the chest, I'm pretty sure that was a lung that was in the way. We can see that. Whereas if they had like a 22 round and that thing gets shot, let's say the guy gets shot in his calf. We don't have an exit wound. That thing could come out all the way up by by the shoulder or something, because it's just ricocheted all around in the body. So that trajectory of that bullet and the fragments of it, it's been changing and bouncing all around. So that's what they're talking about when they say trajectory. I'm gonna get you to say trajectory because I'm having a hard time with that one. The drag on that one, I actually don't fully understand the drag on that one. So if somebody I don't want to say gun nut, but a ballistic specialist out there, I know we got a couple of them in the department. If you want to add to that, please let us know, because I want to understand the whole drag concept. The profile, we're talking about the shape of the object. So a rifle round is nice and tapered. It's like a little nose cone versus a buckshot. A buckshot is a lot bigger. It can push out more meat as it goes through. Those types of things will also affect the type of injury you're going to have. And I've already talked about the cavitation. Just remember, the cavitation is when the material, the meat, the flesh around the wound channel is violently stretched apart, and then it violently closes back. That's that cavitation. And then the fragmentation, that's just when the bullet breaks apart. All right. Gunshot wounds. We see that 90% of fatal wounds involve the head, thorax, and abdomen. Why is that? Because that's where the important stuff is. You get shot in the head, you got a lot of important things there, so we don't want that one.
Got shot loose in the thighs for some reason.
Well, I mean, they got something very important there too. Absolutely, absolutely. But we're looking at the textbook, so you can tell when somebody gives me something to read, I start stuttering. He just wants to see me mess up. But there you go. Wounds also to the neck and extremities, they can be an issue as well too, especially the neck. All right. Well, then that's going to be it for that. I believe Firefighter Mac is going to be here in just a minute. So I really appreciate you guys, and we'll see you on the other side. We're going to pause it for a second.
For the last section of this presentation, we're going to talk about multi-system trauma, the trauma system, triage, patient packaging, patient movement. We're going to first start by reading a case study. Nina and Scotty ensure that the patient has an open airway and is breathing adequately. They apply oxygen via non-rebreather as a police officer continues to apply direct pressure. Nina detects a weak, thready radial pulse that she estimates to be greater than 100 beats per minute. She performs a rapid secondary assessment, during which time she finds an entry wound to the front of the thigh and an exit wound posteriorly. Meanwhile, Scotty is preparing a long backboard so they can prepare the patient for transport. What factors should the EMTs consider in determining where the patient should be transported? Most trauma patients have a simple or single injury. However, some trauma patients may be experiencing multi-body systems or multiple injury sites. A multi-system trauma has a high incidence of morbidity and mortality. Managing immediate life threats and expeditious transport are the appropriate care. We're going to next discuss the golden principles of pre-hospital trauma care. The golden principles of pre-hospital trauma care apply to all patients who have experienced some type of injury, but especially those with multi-system trauma or critical injuries. Several special considerations in trauma care. The first is that your safety and your safety of your crew is of the highest priority. Airway management and adequate ventilation and oxygenation are key elements of trauma management. We must stop any significant bleeding. Assessment of the trauma patient is conducted in a systematic sequence. Rapid transport is essential to survival of severely injured patients. A backboard can serve to splint fractures in unstable trauma patients, as well as many other applications and devices that we may have access to can also accomplish this. Do not develop tunnel vision and become focused on dramatic injuries or patients. We're also going to talk about the golden period in the platinum 10 minutes. The best chances of survival for trauma occurs when intervention takes place as quickly as possible. The goal is for EMS providers to limit scene time to 10 minutes with severely injured patients. This is referred to as the platinum 10 minutes. Within the 10-minute scene time, you must assess the patient, manage immediate life threats, and prepare the patient for transport. Indications for on-scene time of 10 minutes or less in rapid transport include airway occlusion or difficulty in maintaining a patent airway, respiratory rates less than 10 per minute or greater than 29 per minute, inadequate tidal volume, hypoxia, respiratory distress failure or arrest, a suspected skull fracture, flail chest, suspected pneumothorax, hemothorax or tension pneumothorax, pelvic fracture, 2 or more proximal long bone fractures, crushed or mangled extremities, uncontrolled external hemorrhaging, suspected internal hemorrhaging, signs and symptoms of shock, significant external blood loss with controlled hemorrhage, a Glasgow Coma Scale 13 or less, altered mental status, seizure activity, sensory or motor deficit, any penetrating trauma to the head, neck, anterior or posterior chest, abdomen, and above the elbow or knee, amputation of an extremity proximal to the finger, trauma in a patient with significant medical history, such as a previous heart attack or COPD, congestive heart failure, also greater than the age of 55, hypothermia, burns, or pregnancy, multi-system trauma, open or depressed skull fracture, suspected brain injuries, or paralysis. Remember that for paralysis, we check pulse, motor, and sensory on all 4 extremities. The patient does not have to be conscious and alert to do this. Make sure that you're checking for pulses and also reflexes. The absence of reflexes could be an indicator of paralysis. The trauma system exists to provide immediate surgical intervention for critical injured trauma patients. Different levels of trauma centers have different levels of capabilities. This care dramatically reduces the morbidity and mortality of patients requiring immediate surgical intervention. Most of the time, trauma systems are designated by either level 1, 2, 3, or 4. As you can see here, level 1 is usually a regional trauma center, level 2, area trauma center, level 3, community trauma center, and level 4, trauma facility. We are very fortunate here in Greensboro to have a level 2 trauma center at Moses Cone Hospital. Here you see ground transportation units from Guilford County EMS and CareLink. Most of our trauma patients here in Greensboro will be transported to Moses Cone ER immediately. We also, in the state of North Carolina, have 17 designated trauma centers, Cone Health being one of them. Cone Health is a level 2, however, we do have 3 level 1 trauma centers within our vicinity. Those include Carolinas Medical Center in Charlotte, Duke University Hospital in Durham, as well as North Carolina Baptist Hospital in Winston-Salem. Understanding that difference between level 1 and level 2 is a state designation. Level 1 trauma centers usually meet that designation through research and publications as well. Ground transportation is the mode of transportation that we most commonly see here in the city of Greensboro. However, depending on the traumatic injuries the patient is experiencing and the location of where that patient is, air transportation may be used to get them to a level 1 trauma center or to a specialized facility. This especially could occur during long extrication times during a motor vehicle accident. Next, we're going to discuss guidelines for field triage of injured patients. Usually this is a step-by-step process. It's systematic. It usually starts with assessing our ABCs. If you look at this chart, the Glasgow Coma Scale, less than 14, a systolic blood pressure less than 90 millimeters of mercury, or respiratory rate less than 10 or greater than 29. If the patient meets that criteria, they automatically qualify to be taken to a trauma center. Step 2 focuses more about penetrating injuries, amputations, pelvic fractures, flail chest. If they meet any of those requirements, then yes, they would go to a trauma center. Step 3 looks at falls and high-risk auto crashes, mechanisms of injury, significant damage. Just remember that significant damage of a vehicle is not by itself, does not necessarily mean that that person will go to a trauma facility. It is based off not only mechanism of injury, but your assessment of that patient and scene safety. Step 4 talks about age, also talks about anticoagulation disorders where the bleeding will not stop. Could also be involved with burns or a time-sensitive extremity injury, end-stage renal disease requiring dialysis, pregnancy, or simply EMS judgment could decide to go to a trauma facility based off of those criteria. I'd like to talk a little bit about patient packaging and movement. Remember that patient packaging and movement are based on usually 3 different factors. The mechanism of injury, in other words, the scene size up, what you see, the type of injury, whether it might be a car wreck, the type of damage to the vehicles involved. Next would be the patient condition, findings on your primary assessment. Are they stable, unstable? Do you have multiple systems involved? And then third, talk about scene safety, safety to the patient and us as responders. These three factors are going to help to determine how you're going to package and move that patient. Typically, we talk about three different types of patient moves. An emergency move would be a fast move. Spinal stabilization would not be performed. And when the scene is not safe, there is an immediate danger to both patient and rescuer. A great example of this would be for a MVA where one car might be on fire, or you might have an issue or an unstable vehicle. You may make a decision to make an emergency move. If you do not make this move, there is danger to you or the patient. Urgent moves, even though that they are fast, we take the time to actually do spinal immobilization, and the scene is safe and there is no immediate threat to us. Usually that patient is going to be unstable, and we're going to need to make an immediate decision on how we're going to package and move that patient. Non-urgent moves is where we have a safe scene. The patient may be stable at this time, and spinal immobilization may or may not be performed based off a patient assessment. Just remember that even though we are working with a sense of urgency, we need to make sure that we're doing the best that we can to provide patient care and also our safety. Case study conclusion. NENA consults with medical direction concerning their destination for the patient. There is a community trauma center 20 minutes away and a regional trauma center 70 minutes away. Medical direction advises transport to the community trauma center where the patient will receive initial stabilization. It is likely the patient will be transferred to the regional trauma center for definitive care. We often see this when specialized injuries or mechanism of injuries where the patient may be transported to the closest facility to get that patient stable, and then either that patient will be transported through critical care ground transports or through air transportation. That concludes this presentation. Be safe out there.